Good morning, everyone. Today we'll be dealing with shoulder biomechanics. The contents are functional anatomy, joints of shoulder complex, glenoid labrum anatomy, ligaments of shoulder joint, shoulder stability concept, that is static, dynamic, circle concept of instability, and shoulder sleeve mechanism. When we are talking about functional anatomy, shoulder complex, it is a complex, it is not a mere joint. That means joint needs two bones to form a joint. When two bones are coming close together, they form a joint. But complex is something which consists not only of two bones, a little more than that. Let's look into what is shoulder complex made up of. Sternum, 1, clavicle, 2, scapulae, 2, ribs, vertebrae, thoracic vertebrae, humerus, 2, for to form two shoulder complex. Let's look into each other in detail. Clavicle. It is divided into two parts, that is lateral one third and medial two third. Lateral end is known as acromial end as it forms a joint with acromion process of scapulae. Medial end is known as sternal end as it forms a joint with sternum known as sternoclavicular joint. Coming to the functions of clavicle. First one, it resists compressive force. Second one, it is known for stability of the four upper extremity. Third point, it is the only connection between upper extremity and the trunk. Coming to movements of clavicle. First one, elevation and depression. Second one, upward rotation of the clavicle and downward rotation of the clavicle at sternal end. Third one, protraction and retraction at the acromial end. When we are talking about protraction, retraction, it is very difficult to put it in the slides or the video because it is a 3D movement. The axis for protraction and retraction is at sternoclavicular joint. Coming to scapulae. Scapulae is a flat bone placed posteriorly, elliptically on the rib cage. It has three borders, that is medial, lateral, and superior, two angles, superior and inferior, one spine, that is your acromion process, and four fosses, that is supraspinous fossa, infraspinous fossa, subscapular fossa, and glenoid fossa. The main functions of the scapulae are provide stability for the upper extremity during movement, allows 3D movement for the entire upper extremity. Talking about movements of scapula, first one, elevation and depression, where your scapula translates itself vertically up and down. In each direction, elevation and depression are about 12 centimeters respectively. Coming to upward and downward rotation of the scapulae, 60 degrees occur in upward rotation direction, also 60 degrees occur in downward rotation direction of the scapula. Coming to protraction, where your scapulae come together, that is not also called as adduction of the scapula, and retraction is going away from each other, also called as abduction of the scapula. It is 15 centimeters in either direction. Coming to anterior and posterior tilt. The first one in the video is posterior tilt, where your scapula is tilting posteriorly, and the second one is anterior tilt, where your scapula is tilting anteriorly. Coming to the muscles of the scapulae. First, we'll deal with posterior view of the scapula. These are the muscles which are present posteriorly on the scapula. Few important muscles are levator scapulae, trapezius, rhomboid minor, rhomboid major, and your lat dorsi. So, when we are talking about scapulae, first thing which comes to our brain is rotator cuff muscle. Among rotator cuff muscle, the posteriorly placed muscles are supraspinatus, infraspinatus, and teres minor. Coming to the anterior view of scapula, coracohumeralis and biceps brachii, pectoralis minor, omohyoid muscle, long head of triceps brachii. Again, a part of sits is not that is nothing but your rotator cuff is present on anterior view of the scapula as well. That is your subscapularis. There's one more muscle which is present on anterior view, which is inserted into the medial border of scapula, a very important muscle known as serratus anterior, which has 8 digitations. These were the myology. or anatomy of muscle. Coming to joints. There are two joints when we are dealing with scapulae and clavicle. That is your acromioclavicular joint and sternoclavicular joint. First, we'll deal with sternoclavicular joint. It is a joint forming between clavicle and sternum. Short form to right sternoclavicular joint is SCJ. Sternoclavicular joint is a synovial sellar joint. The type of joint is synovial sellar joint. The functions of the joint are this is the only skeletal articulation between upper extremity and axial skeleton. Second point, it is palpable because only lower part of the clavicle articulates with the sternum, whereas upper end is not. You can see that in the image, the lower part is only articulating, whereas upper end is not. Capsule is lax of this joint. The ligaments only provide stability. Let's look into what are the ligaments of sternoclavicular joint. First one, interclavicular joint. There's exactly same sternoclavicular joint on the opposite side. So definitely there must be some connection between the clavicle, one side of the clavicle to the other side of the clavicle. The ligament which connects both the clavicle is known as interclavicular joint. Second one, sternoclavicular ligament. Third one is costoclavicular ligament. Coming to the acromioclavicular joint. Type of joint is synovial joint. The functions are lax capsule and strong ligament support. Acromion flat or slightly convex, whereas clavicle is flat or slightly concave. The ligaments of acromioclavicular joint are acromioclavicular ligament, coracoclavicular ligament, and coracoacromial ligament. Coming to the variants in the shape of acromion. When we know acromion is which was mentioned in the previous slide, that acromion can be slightly flat or slightly convex. So we know that there are different types of acromion, which can be normal as well, which can be abnormal. So depending on the shape of acromion, there are three types. One is flat, second one is curved, and third one is hooked. You can see in the image, the green part is not, this is the transverse view of the shoulder joint. This is how you have to draw. The green color in the flat acromion is nothing but your acromion part, which is flattened at the end. The curved acromion demonstrates a curved part of the acromion in a pink color, whereas hooked acromion demonstrates the hooking of something, which is nothing but your acromion, which is demonstrated in your orange color. Let's look at the subacromial space in each of the variants of acromion process. The first one demonstrates very good space, the second one demonstrates reduced space, whereas the third one demonstrates very much less space. When you know that the space that is subacromial space, the space beneath the acromion process is reduced, there occurs impingement of the rotator cuff. Hence, the impingement syndrome of rotator cuff is maximum seen in people who have hooked acromion and least seen in people who have flat acromion because of the space change. Coming to glenohumeral joint. Glenohumeral joint is the joint formed between the scapular part of glenoid fossa, a part of the scapulae, and humeral head, a part of the humerus. The type of joint is ball and socket synovial joint. It has very unstable articulation because here also, as we saw in sternoclavicular joint, only a part of the humerus is articulating with the part of a glenoid fossa. The head of humerus faces medially, anteriorly, and superiorly. The neck shaft angle is equal to 130 to 150 degree of the humerus. Retroversion angle is equal to 20 to 30 degree of the humerus. Glenoid fossa is placed 5 degree posteriorly and superiorly inclined. We already know that the unstable articulation may lead to some type of dislocation. To inhibit that, God has given the glenoid fossa to be superiorly placed slightly. By how much amount? That is your 5 degree. So your one main important factor is glenoid fossa, which is placed 5 degree posteriorly and superiorly inclined, inhibits the inferior dislocation of the humerus. Coming to arthrokinematics of the GH joint, that is your glenohumeral joint. First one, flexion extension. We'll see the video. During extension of the humerus, the humeral head slides. Which direction can you, we'll just look into the video first. This is extension and this is flexion. So, in during flexion, that is forward elevation, humeral head slides inferiorly, rolls posteriorly, and exactly opposite occurs when you do extension. That is, when you do extension, humeral head slides inferiorly, rolls anteriorly. This is the arthrokinematic of flexion extension. Let's look about abduction adduction. Just look at the video first. So this was abduction and this is adduction. So during abduction, humeral head slides inferiorly, rolls superiorly, whereas during adduction, humeral head slides superiorly and rolls inferiorly. Coming to medial and lateral rotation. During external rotation, humeral head slides anteriorly, rolls posteriorly, whereas during medial rotation, it is exactly opposite. Coming to shoulder shirt sleeve. As we talk about joint, we know that joint is covered with the capsule, tightly or little bit relaxed at the area of joint articular surfaces. But when we are talking about shoulder complex, the capsule has redundancy. That is, it is very loosely attached on the inferior aspect. That is nothing but your shoulder sleeve. It is called a shoulder sleeve because it gives the room to the humeral head for maximum mobility because the capsule is redundant in inferior aspect. Coming to chalk block mechanism. As the word tells, there is something getting blocked. Let's look into what it is. Consider the down part to be scapulae. That is your glenoid fossa, and the circle to be your humeral head. As you can see, the end of the rectangular part is elevated. That is nothing but your glenoid fossa. The glenoid labrum covering the periphery of the glenoid fossa is elevated. So what this does, this elevation inhibits the slippage of the circular part, that is your slippage of the humeral head on any trauma. This glenoid labrum is elevated throughout its circumference. That is, entire circle is elevated of the glenoid fossa by your glenoid labrum, thus protecting or inhibiting the humeral head to slip out of the fossa. That is nothing but your chalk block function. Coming to shoulder stability. First, let's deal with first mechanism, that is your static mechanism, bony. We already know the part, only little part of the humerus is articulating with the little part of the scapula. That is, only few percentage of the entire head of the humerus is articulating only with few percent of the glenoid fossa. So now we got to know that bony in static mechanism has the least importance. Coming to ligamentous. There are many ligaments in shoulder complex. The three important ligament when we are talking about glenohumeral joint is coracoacromial, the yellow color, coracohumeral, the tannish pink color, and then comes your GH ligament, that is your glenohumeral ligament. Glenohumeral ligament is divided into three parts. That is, sorry, that is your superior glenohumeral ligament, medial glenohumeral ligament, and inferior glenohumeral ligament complex. Glenohumeral ligament, as I told, is very important because it holds the head of the humerus attached tightly to the glenoid fossa of the scapulae, thus preventing dislocation of the humeral head. It is acting exactly in the same way as your glenoid fossa had tilted superiorly and posteriorly for about 5 degree, which is trying to avoid the inferior displacement of the humeral head. Coming to capsular obligate translation. Just look at the video. I'll repeat it again. Just look at the video. See, I have already told you that the down part, the inferior part of the diagram is consider it to be your scapulae. The circular part, consider it to be your glenoid fossa. The round part, consider it to be your humeral head. What happens in capsular obligate translation is split the term. Something is happening to the capsule which is causing something to get translated in opposite direction. That is nothing but your capsular. Something is happening to the capsule, obligate, opposite, translation, direction of movement. So, if something happens to the capsule, it causes the humeral head to translate in opposite direction. So, if some, this is your joint, if some force is acting on the anterior aspect in a very bad manner, this is causing the humeral head to translate itself posteriorly. This is not only in the relationship between anterior and posterior, it is multi-directional. If one way the trauma is happening, the other way, in the other direction, your humeral head is moving. Hence, this is known as circle concept of instability. Coming to the next point, we saw what is static shoulder concept, in which we saw joint bony, ligamentous, and joint pressure and volume. We saw capsular obligate translation. We saw circle concept of instability. We saw dynamic stability of the. Now we are seeing dynamic stability of the shoulder. First point, rotator cuff muscle. I have already explained you rotator cuff muscle that is sits. This is all anatomy. That is your supraspinatus, infraspinatus, teres minor, and subscapularis. Second point, in dynamic stability is your force couple. Let's look into each other in detail. Scapular force couple, humeral force couple. What are they? Coming to scapular force couple. When we are talking about any bone and the force couple, we know that the bone movement, we are describing the bone movement occurring due to the force couple of the muscle which are attaching to that bone. So here we are dealing with scapular force couple. So which bone is moving in scapular force couple? Scapula. What are the muscles which induces scapular movement, which are attached to the scapula? Definitely. So we'll see what happens in scapular force couple. Taking an example in scapular force couple, which is easy to understand, is your upward rotation of the scapula. So scapula is getting rotated to 90 degree. Look at the rotation of the scapula to 90 degree when your upper trapezius and lower digitation of serratus anterior are pulling the scapula. I'll demonstrate it again. Scapula is rotating to 90 degree, 0 to 90 degree, not 0, sorry, 30 to 90 degree when the scapula is getting pulled by upper trapezius and lower digitation of serratus anterior simultaneously. Is this the discussed this thing upward rotation degree? No. Scapula can still rotate further. That is from 90 to 150 degree. That is caused by lower traps, lower trapezius, and upper serratus anterior simultaneously. This is nothing but your scapular force couple. Coming to humeral force couple. Moving bone is humerus. Muscles which are causing the movement of humerus is attached definitely to the humerus. When we saw scapular force couple, there were only two muscle acting at a time. But when we are dealing with humeral force couples, entire rotator cuff is needed because in order to move the shoulder extremity, sorry, upper extremity, the shoulder complex, especially your rotator cuff must be very active. It is the very important part to know that rotator cuff provides dynamic stability to the glenohumeral joint as well as shoulder complex because they are originating from scapulae and getting inserted into the humeral head. So, when we are dealing with glenohumeral fossa, we know that we are dealing, humeral fossa couple, we know that we are dealing with glenohumeral joint. So, on one side, let your rotator cuff be. As I already told, rotator cuff is very much needed for causing any movement at GH joint, that is your glenohumeral joint. I already told you in the last slide that there is, if a force coupled term comes, there should be two different set of muscles. So considering rotator cuff is one-sided action, producing your shoulder joint movement or GH joint movement, providing one-sided force pulling the humeral head into the glenoid fossa, there must be a limiting factor to rotator cuff that is caused by your multi-directional fiber muscle, the bulkiest muscle known as deltoid. Please remember, deltoid changes its vector direction according to its muscle fiber activation. If the shoulder joint is at rest, 0% of the compressive force is provided. If the shoulder joint is in flexion direction, the shear force or the vector direction is superiorly away from the joint. If it is in the 90-degree abduction, the shear force or the vector direction is into the scapula. So rotator cuff centralizes the humeral head, whereas deltoid limits the displacement of the humeral head. Coming to osteokinematic, that is just the degree. Coming to flexion extension, I already showed you all how the flexion extension occurs of the humerus over the glenoid fossa. The flexion degree is 0 to 180 degree, whereas extension is caused between 0 to 30 to 40 degree. This is not called as hyperextension. This is pure extension of the shoulder, which is 0 to 30 or 40 degree. Coming to abduction and adduction. Abduction is about 0 to 180 degree, whereas adduction is nothing but 180 to 0 degree. There is some term called as horizontal abduction and horizontal adduction, where your horizontal adduction is not 0. Coming to medial lateral rotation. Imagine this is a person standing. He is going to flex his elbow at 90 degree to do medial and lateral rotation. For about lateral rotation is 0 to 90 degree, whereas the medial rotation is 0 to 70 degree. Coming to last final part, pathomechanics of the shoulder joint. First part in which tells instability. There are two mnemonics to remember instability, Tubbs and Ambry. Tubbs states that first T, traumatic, that is some trauma has occurred which is causing acute dislocation. Dislocation is nothing but when a bone is moving completely away from its parent bone. This is nothing but your dislocation. And subluxation is nothing but when a bone is not completely moving away from the parent bone but still in contact with the parent bone. That is nothing but your subluxation. So instability is occurred when it is traumatic and there is acute dislocation, usually seen unilateral with presence of Bankart lesion. The treatment main line should be surgical stabilization or a sling is provided, which is conservative. What is Hill Sachs and Bankart lesion? Let's look into the diagram. The pinkish shaded part is your scapulae, whereas the yellowish part is your humerus. When we are talking about Bankart's lesion, it is the lesion of the glenoid labra. You can see there's something torn from this part, that is your Bankart lesion. And this the head is not looking normal. There is some trauma occurred to the head which is depressed. The head in the posterior side is depressed. That is nothing but your Hill Sachs lesion. So Hill-Sachs lesion tells that compression fracture of posterior humeral head as it slips over the sharp edge of the anterior tip of glenoid fossa. Bankart lesion tells that capsular avulsion or the stretch of a capsule in the posterior part of glenohumeral capsule, causing the redundancy to migrate anteriorly and inferiorly. This is nothing but your Bankart lesion and Hill-Sachs lesion. Coming to subluxation and dislocation. When we are, I just explained you in last slide what is subluxation. Subluxation is nothing but a bone moving away from its normal alignment but still in contact with the parent bone. Whereas dislocation is loss of the contact with the parent bone. This is nothing but your subluxation. It has moved away from its alignment, whereas this is nothing but your dislocation. This is anterior dislocation. This is posterior dislocation. This is your inferior dislocation. Coming to ambry. A is nothing but atraumatic, whereas in tubs, T was nothing but traumatic. M is nothing but multidirectional, whereas in U, that is in tubs, U was unilateral. Here B is nothing but bilateral. R stands for rehabilitation, whereas over there in tubs it was S stating surgical stabilization or conservative management via sling. I stands for inferior capsular shift. Coming to method of GH instability classification. It is classified on four bases. That is, first one, frequency, how frequent it is, acute or occurring again and again, also known as recurrent. Second point, degree, that is subluxation or dislocation. Third point, etiology, or traumatic in the cases of myopathies or neuropathies, traumatic in the cases of falls or accidents. Fourth point, direction, in whichever direction the head slips out, that is your anterior, posterior, inferior, or multidirectional. Last part of the pathomechanics of shoulder complex, that is your six scapulae. Six scapula is nothing but when there is any prominence of any part of the scapulae. Depending on the prominent part of the scapulae, it is graded into four types. Let's learn what does six stand for. Every word in every letter in the sick word has a meaning. S stands for scapular malposition. I stands for inferomedial border prominence, that is inferior and medial border of the scapula being prominent. C stands for coracoid pain and K stands for dyskinesis of scapular movement. This is nothing but your sick. The full form of sick is scapular malposition for S, inferomedial border prominence of the scapulae for I, coracoid pain for C, and dyskinesis of scapular movement for K. Now, what are the grades of six scapulae? Sorry, what are the grades of six scapulae? First one, it is just prominence of inferomedial border. Second grade states that it is prominence of entire medial border. Third grade states that it is prominence of superior medial border. Only superior medial border of the scapula is prominent. Whereas fourth grade stands for entire scapula from inferior to the superior border is prominent in static position. These are the four grades of the six scapulae. I'll repeat it again. The first grade stands for prominence of inferomedial border of the scapulae. Second grade stands for prominence of entire medial border of the scapulae. Third grade stands for superomedial border prominence of the scapulae, whereas fourth grade stands for entire scapula being prominent from inferior to superior in static position. These were the six scapulae grades, and this was the end of the lecture. So we'll meet